Our next presenter is Maureen Sauvé, a patient advocate. She is the past president of Scleroderma Canada, Scleroderma Ontario, as well as being a scleroderma patient. Maureen Sauvé.
Good afternoon. As a patient advocate, I am aware that there are many barriers in accessing treatment for scleroderma patients. I will attempt to outline a patient's perspective. The first barrier is the lengthy time to diagnosis. In a 2007 study of 650 Canadian scleroderma patients, the mean time to diagnosis from onset of Raynaud's phenomenon was 6.1 years. The mean time to diagnosis from the onset of non-Raynaud's Raynaud's symptoms was 2.7 years, significantly longer for women at 2.9 years than for men at 1.4 years. In a 2010 survey, average time to diagnosis was reduced to 17 months, certainly improved, but we still have a long way to go. While the onset of Raynaud's is not uncommon in the adult population, it is the additional symptoms such as swollen fingers, pain, and fatigue that should be signals for physicians to look for underlying causes. Unfortunately, these symptoms are often not considered serious by primary care physicians. It is hypothesized that because more than 80% of these patients are women between the ages of 40 and 50, these symptoms are often written off as menopause related. This period is tremendously frustrating for patients and their families, with 80% of patients reported seeing 2 or more doctors in order to get a diagnosis. It is during this stage that patients start to Google their symptoms. Not the best way to receive a diagnosis or any level of medical care, but unfortunately, it becomes necessary sometimes. Education of our primary care physicians about the importance of investigating Raynaud's, particularly in the presence of additional symptoms, is essential if we are to reduce the time to diagnosis and improve access to treatment. Scleroderma is a complex illness that is complicated to treat. To quote Dr. Thomas Metzger, who is considered to be the grandfather of scleroderma research in North America, to know scleroderma is to know medicine. Due to the rarity of scleroderma, most rheumatologists have little, if any, experience treating scleroderma. We believe that access to a rheumatologist specializing in scleroderma will provide the best care, in addition to providing opportunities for participation in clinical trials. Unfortunately, there are few of these specialized rheumatologists in Canada. Ontario is lucky to have 4 such sites in Hamilton, Toronto, London, and Ottawa. The rest of the country is not quite as lucky. Due to the complexity of this illness, coordination of care across specialties is necessary. Time delays between specialist appointments and timely communication across these specialties results in fragmented care. Optimal access to care would require multidisciplinary teams in a congregate setting. Combined clinics are optimal, but not common. When it comes to pharmaceuticals, it's important to realize that there are no drugs that have been designed for scleroderma. Treatment for scleroderma is primarily aimed at controlling or delaying symptom progression. Vasodilators, proton pump inhibitors, ACE inhibitors, calcium channel blockers, and immune suppressing therapies are most commonly prescribed. As a rare disease, off-label use of drugs is not uncommon. However, it can lead to significant delays in access to treatment. An ongoing example is the use of PDE5 inhibitors, sildenafil and Revatio, potent vasodilators used for severe Raynaud's and digital ulcers. While there is significant evidence as to efficacy, there is less robust clinical data. Not an uncommon issue in rare diseases. Its use as a second-line treatment is standard of care in Europe and US, but not in Canada. At a cost of approximately $600 per month, many patients cannot afford this treatment. With a bureaucratic burden for physicians, exceptional access approval is possible, but there is inconsistency in funding approvals. Even with approvals, this comes at a cost of time, When blood flow to a finger or toe is compromised, dilating the blood vessels and establishing better blood flow as soon as possible is critical to minimizing the tissue damage caused by the vasoconstriction and subsequent loss of oxygen to the tissues. Time delays in treatment result in worse outcomes, including gangrene and amputations. I quote from a survey of 17 scleroderma specializing rheumatologists in Canada, representing 8 provinces. None of the provincial governments provided coverage for PDE5 inhibitors without special requests that were adjudicated on a case-by-case basis, with approximately half the provinces paying for PDE5 upon special request if the patient was eligible for provincial drug insurance. Example, elderly, youth, low-income families. 2 provinces, Quebec and Saskatchewan, provided PDE5 all the time, whereas Nova Scotia, Manitoba, Ontario, BC, and Alberta provided them sometimes. Newfoundland provided them never. Provincial governments and private insurance fulfilled requests within a month, 62% of the time, and the other requests took longer to be answered. Private insurance coverage with special requests in Alberta, Manitoba, Quebec, Ontario, and Nova Scotia. Respondents described administration of IV prostanoids as inconsistent, requiring a lot of work, and that most patients in most jurisdictions be admitted as inpatients for provinces to cover these medications. This is hardly sensible in the era of COVID. We, along with the Ontario Rheumatology Association, have been actively advocating for a change at Health Canada so that this drug can be available on provincial formularies. When you look at a week's delay, never mind a month's delay in establishing blood flow, you can be fairly certain that there's irreversible damage done to fingers and toes, resulting in lifelong disability, functional disabilities. These matters are obviously very important for patients. Delays in access to treatments for these reasons is truly unacceptable. Step therapies, the lumping together of patients for therapeutic areas, can result in problems in our patient groups. For example, there was a therapeutic review of all drugs used for pulmonary hypertension. And the intent was to determine at WHO classification levels patients would be eligible for medications. The problem, of course, is that when you take a subgroup of patients, like scleroderma pulmonary hypertension, the underlying comorbidities and the mechanisms that have resulted in illness are not identical and play a significant role in the effectiveness of treatments. There was much literature that proves that scleroderma patients respond worse to treatment and have higher mortality rates than those with idiopathic PH. And yet the government's decision to lump together for step therapy approaches once again provides an additional barrier for access to combination therapies and newer treatments. In summation, it's very reasonable to say that there are many obstacles to access for treatment for Canadian patients. And we at the Scleroderma Society of Ontario, Scleroderma Canada, and the rest of the associations across the country will actively continue to work to reduce the barriers to therapy for our patients. Thank you.
Thank you, Maureen, not only for your advocacy, but also for sharing your personal journey, your review of, for example, how scleroderma may involve a delayed diagnosis of many months, even years. Unfortunately, that it takes often longer for women to receive the diagnosis, perhaps symptoms often being written off as those associated with menopause, as well as your call to educate primary care physicians so that patients might hopefully not experience the negative effects of searching for medical information and guidance on Dr. Google, as well as your review of the maze of medications and forms and government plans and coverage involved in this area. Thank you, Ms. Sauvé. We'll now move to our live panel discussion. So please do send us your questions on the chat feature through Zoom.